background of the disease. So it's early onset childhood schizophrenia. Usually it is less than 13 years onset. It's a very rare disorder. Usually the prevalence is said to be like in 1 in 30,000 live births. The disease is chiefly characterized by hallucinations, delusions, and most commonly cognitive impairments in children. The disease presents insidiously with a premorbid period of developmental delay or developmental regression with academic decline. Often the disease, due to its complex presentation, it's missed or sometimes it's misdiagnosed with other disorders such as pervasive developmental disorders. I hereby present a rare case of 10-year-old boy who showed behavioral abnormalities which are suggestive of psychosis. Just an introduction of the disease. So it's basically the schizophrenia is a chronic severe mental illness. At least 5% of individuals, they become symptomatic before 14 years of age and up to 40% prior to 18 years of age. As the early onset disease progresses, that would follow more severe and debilitating course with worse outcomes than the adult, which is more than 18 years of age, or the adolescent onset, which is 13 to 18 years of age. Okay, just give me 1 minute. Okay, so the current case report is from a tertiary healthcare center. This explores a comprehensive approach for need for early diagnosis of the illness and prompt initiation of therapy, because the schizophrenia, it has a great variation in its clinical presentation. So due to its missed diagnosis, it will lead to increased duration of untreated psychosis with more negative symptoms in the patients. So that this would attribute to limited treatment options with a very, very worse clinical outcomes. Okay. And I would like to move on to the case presentation. A 10-year-old boy who is a student of 2nd grade. He's from a low socioeconomic status family. He was brought by his mom to adolescent health clinic with chief complaints of poor scholastic performance and strange behavior for the last 2 years. The child was born out of a non-consanguineous marriage and he was first in birth order. The child was apparently normal until 8 years of age, and late his mom noticed a gradual decline in his academic performance over a period of last 2 years. His mom frequently received complaints from his class teacher that he was not actively participating in the school activities, along with reduced interaction with the peers. At home, he wouldn't allow anyone except his mom near him, and he refused to eat food with his family members, and he preferred to be lonely most of the times. He used to mostly laugh and mutter to himself. And when the child was confronted upon his reduced interaction with the people, he was mostly apathic, and he appeared that he's lost in his thoughts. And his mom also noticed that he's not responding to call, not maintaining any eye contact. He appeared to have lost in his language skills, which is evidenced by a terse speech. His teachers also complained that occasionally he picks up fights with peers, he becomes aggressive for no reason, and this behavior has been it's become uncontrollable over the past few months. And there's also a history of school bullying, and the boy's mood frequently changed from cheerful to sad, and he suddenly become irritable. And his mom also noticed that his sleep latency is increased with a decrease in total duration. And the boy also heard some voices conversing, commenting on him, and shouting with someone who is usually not around him. Mom also expressed her difficulty in providing her kid bath, trimming his hair, cutting his nails. And as a result, most of the times the boy looked very untidy. And there's no history of visual hallucinations, repetitive behaviors, catatonia, and seizures. The child had multiple hospital admissions in the past, and he was absent to school multiple times due to the current illness. The child suffered paternal loss, which appears to be his first childhood stressor at 6 years of age. And later, he was exposed to harsh treatment from his stepfather for his behavioral abnormalities. And we took an antenatal history of mother when she was pregnant, and mom had fever, rash, and cervical lymphadenopathy during her first trimester, and she's immunized with TT. She took iron folic acid supplementation as per norms, but she had a poor weight gain during her pregnancy. She had no history of substance abuse, drug intake, gestational diabetes, or preeclampsia during her entire course of pregnancy. And the child was born by a normal vaginal delivery at term with a birth weight of 1.8 kilograms. He cried immediately after birth and admitted in an ICU due to symmetric intrauterine growth retardation. And there's no significant family history of psychiatric disorders. The child's development was normal until he was 8 years. Later, we noted a significant developmental regression in especially the language domain. So upon general examination of the child, he was conscious and coherent, but he had no dysmorphic facies. Neither he had any neurocutaneous markers over the body, but we noted a significant microcephaly. His neck and spine are normal, and his limbs and posture were also normal. He's vitally stable. We took a note of his anthropometry. His weight and height for age were at 50th centile. His body mass index is also at 50th centile, but his head circumference was significantly less than 3rd percentile. We checked the other systems, the cardiovascular, the musculoskeletal, respiratory, and GIT. So everything was normal. We conducted a detailed central nervous system examination. It showed significant impairments in the higher mental functions. He had poor attention, poor concentration, memory, poor judgment, poor rapport, insight, and his speech and language were also impaired. We conducted a detailed IQ assessment. Unfortunately, we couldn't do it in a single time. We needed a multiple assessments because he was very attentive and he's not cooperative. However, we got the child to be a borderline mental retardation. His IQ was around 70. His appearance was poor. He was with abnormal behavior, and he's already apathetic, and he used to be in a dull mood. We noted some auditory hallucinations, but there are no abnormalities in cranial nerve, motor systems, cerebellum, and autonomic nervous systems. And consequently, there were no signs of meningeal irritation. So we conducted a comprehensive approach. So we started basically with a hemogram, the complete blood picture. We noted normal parameters in the hemogram. His metabolic panel, that is his thyroid, his renal, his liver functions were normal. And we also conducted a CSF examination. It's normal. And his electron encephalography during his mood changes is also normal. But we did an MRI brain, that is a neuroimaging of the brain. It revealed significantly bilateral frontal cortical atrophy with ventriculomegaly. So due to history of severe intrauterine growth retardation during his neonatal period, and mom has positive history of fever with rash and cervical lymphadenopathy, and she had a poor weight gain during her pregnancy. We conducted serum IgG of rubella, which was significantly elevated. So this is the detailed neuroimaging of the kid. So this is the axial T2 weighted MRI brain. In our present case, it showed significant ventriculomegaly. The blue arrow, which is pointed, as you can see in the screen, is the significant enlargement of the bilateral ventricles. And this is the second one. This is a sagittal T1 weighted MRI. It is showing the blue arrow, as you can see on the screen, is frontal cortical atrophy. And the white ones, which are pointed, shows corpal callosal thinning. So the differential diagnosis includes, due to its similarity with the other disorders such as pervasive developmental disorders such as Asperger's syndrome, neurodegenerative disorders, mood disorders, and ADHD, often it makes us difficult to identify the schizophrenia from other disorders. So we treated the child. He was diagnosed as early onset childhood schizophrenia with predominant negative symptoms, probably due to intrauterine infection and early childhood stresses. He was started on therapy with risperidone. Initially, we started on 2 milligrams per day initially, and then the dose was gradually increased to 4 milligrams per day, along with the psychosocial interventions such as cognitive behavioral therapy. So after a therapy for 6 weeks, we noted a gradual improvement at a follow-up. He showed actually remarkable improvement in his behavior. He became more engaged with his family members and at school with peers. His mood improved. But unfortunately, cognitive impairments continued, probably due to the cortical loss at the frontal area. Studies demonstrated worse clinical outcomes in early onset schizophrenia than in adult onset, displaying higher global disabilities with a deteriorating course. So just a brief discussion. So schizophrenia in childhood is extremely rare. Sometimes it's undetected, and its frequency is up to 50 times lower than the adulthood. 75% of the children, they had a gradual development of the disease. When an individual has early onset schizophrenia, they often have a subtle mental delay, such as in the language impairments, motor problems, and also typically lacking the social skills. So the positive symptoms in the schizophrenia include simple auditory hallucinations, while more frequent negative ones include flat affect or inappropriate mood and delusions that are less complicated than we observe in the teenagers. In addition to the genetic factors, environmental factors such as prenatal maternal infections, like in our case, or early childhood stressors, as in our case too, they play a role in schizophrenia pathogenesis exactly on congruence with the current case. So schizophrenia in childhood, it can be dependently diagnosed using the criteria as that of the grown-ups. So it has significantly smaller frontal lobes as well as smaller cerebrums, smaller craniums, and these findings are consistent with some type of early developmental abnormality associated with prominent negative symptoms and cognitive impairment. Typically, the CT brain, it showed increased cerebral ventricular size as a highly significant predictor for the cognitive impairment. The children with schizophrenia, a poor outcome is often linked to more severe developmental problems, which underlines the necessity for long-term pharmacological therapy along with psychosocial interventions, as in case we started the cognitive behavioral therapy. So I just want to conclude that according to the neurodevelopmental theory of schizophrenia, environmental or genetically programmed events in utero, they disrupt the development of the brain structure and the function. So the current case report highlights the importance of treating the prenatal maternal infections, especially the TORCH panel. So we need to prevent and also eliminate the childhood stressors. So studying patients like these, they might help us better understanding the course of the disease so that the children presenting with early childhood schizophrenia were not exposed to more negative symptoms, so that we can start therapeutic intervention early for the better clinical outcomes. So thank you so much for providing this great opportunity. Do you have any questions?
Thank you so much for your wonderful presentation. I guess we have no questions from the audience, so we'll move on to our next presenter. I would like to